I'm Patricia Thaine, co-founder of Private AI, and this is the Data Frontier podcast. Here we explore the frontier of data innovation, where unstructured data meets real-world applications. Each episode brings together builders, engineers, data scientists, product leaders, and domain experts who are shaping the future of intelligence systems. From NLP and privacy to interoperability and AI-driven workflows, we unpack the tools, challenges, and breakthroughs, transforming raw data into smarter systems, faster insights, and better solutions. So pleased to have Sam and Michael with us today at the Data Frontier podcast. Sam, why don't you give us a bit of an introduction of yourself?
Thank you. So Sam Schifman here. I've been a software architect for about 25 years now, actually, across a number of different industries. I started out in finance, did some HR and some education, back to finance for a while. And then about 5 years ago, joined a company called Diameter Health as the chief architect there. And what Diameter Health did was specialize in trying to make a useful asset out of electronic health data. Which is a much more interesting problem than I thought it was going to be when I joined, to be honest. But it was a great ride. It gave me an introduction to healthcare, IT, and to HL7, where I'm currently working with them on standards around consent management and also AI transparency in FHIR, which is the new healthcare standard for anybody who hasn't heard of fast healthcare interoperable resources. Diameter Health ended up getting acquired by a company called Avality. As you can imagine, Avality already had a chief architect. And I stayed around a little while to see that through. But then I ran into Dr. Ryan Vega, who used to do innovation for the VA and had moved on to this really interesting company called Vantiq, which specializes in a platform for building and operating intelligent systems at scale. And he showed me this, and it just really went home to me that this was what healthcare needed to be successful. And so I had to jump over, and now I'm the innovation architect for healthcare at Vantiq, where I help people think about how they're going to use new technology to really solve problems in healthcare.
Brilliant. Sounds like a great job. Michael, do you mind going next?
Yeah, thanks, Patricia. I'm Michael Lynch. I am originally from Ireland. I have a background in engineering. I did a PhD in computer vision, so essentially machine learning, focused on medical imaging. After that, I worked at a large company called Siemens, which we did pull lots of different imaging data together to build models to identify issues in cardiac, oncology, that kind of stuff. Yeah, and then I've been working in lots of different spaces, both startups and large healthcare organizations as well, both in Canada and the US. I'm currently working as a product on the product team at the Digital Innovation Group at Providence Health, which is a large health system on the west coast of the US. And we're building tools to support their patients and their clinical staff and administrative staff. And yeah, excited to talk about the opportunities of AI in healthcare.
Yeah, you've both recently done had several discussions and talks on healthcare data infrastructure, in particular as it relates to AI. I know you're doing some really interesting work on HL7, Sam, as it relates to that. Mike, you've been doing a lot of interesting work with regard to MCP and healthcare AI. Why don't you guys take us through what is the ideal infrastructure in your eyes for enabling AI in healthcare?
Sure. I mean, I think it's such an exciting time to be bringing technology into healthcare because of the possibilities of doing things which we never could have considered before, right? And I think that agentic stuff opens up this possibility for what I call adaptive automation, which is the ability for the person to work with the computer to solve problems, as opposed to just having the developer know what the problem was ahead of time and build an app that can help solve that problem. I think that's a real possibility, but you obviously need the right infrastructure to make that possible, right? I think that a lot of the work I see around the MCP and A2A really are going to make a big difference in our ability to have these things interop with each other. But I think, one of the key pieces is going to be to have a asynchronous communication protocol or infrastructure that actually supports that ability for all of these pieces to talk to each other and maintain context and also learn over time and so have memory. So I think that those are, two key pieces, which I think, MCP and A2A are starting to help with, but we need another step, which is to understand how is this communication and the context really going to get maintained over time, and how are these systems going to learn, in order to do that, have some memory about how they've worked in the past. I don't know, Michael,
Yeah, and
what you're seeing at Providence.
yeah. I mean, I can speak more generally. I think across healthcare, I think Sam, you hit the nail on the head, right? Like, there's so much scope to solve problems within healthcare. We know that there's a lot of underlying root causes for the increase in costs within healthcare. And I know that you've talked about this in the past, Sam, as well, around the aging population across many different nations. The populations are getting older. And because our treatments are getting better, they're carrying a lot more chronic diseases and these comorbidities that are really new for the healthcare space to maintain health for these patients over the long term. And they're also generating lots of data as well, right? Because they have these lots of conditions and they're living longer. There's just so much information for healthcare teams to try and grapple and understand. And the work that you've been doing, Sam, in HL7 has been trying to organize that data, but still, it's so complex that when you talk about the infrastructure, Patricia, and you want to figure out what that infrastructure is, I think the infrastructure has been trying to maintain a very complex data for a long time and trying to keep up with it. But I think, like Sam said, there's a lot of opportunities with AI and having the ability to take some of this less structured data or even sparse data to make it a lot more helpful. And not just at Providence, but I think across health systems, like worldwide, basically, there's a large number of use cases that are apt to apply this technology to. I'm like you said, Patricia, I'm fascinated by how we can leverage these new tools, like Sam was saying, like MCP, like agents, which have like a brain of an LLM, but have lots of different tools and different capabilities available to them to actually work in this sort of messy environment.
I love that you brought up the aging population, because I think that that's one of the really key problems that we have. The way I see it, there's basically 4 key problems that we have right now in healthcare. One is the aging population, which is really the case worldwide. What is it? It's the U.S. thinks that in 2030 we'll have more people over 65 than under 18 in the U.S. And that's already true in Japan, and I know that these numbers are looking similarly in Canada and all over the world. But there's also other problems where we just have a lack of medical professionals, right? Particularly in the U.S., we're looking at a big deficit, but I think even worldwide we're looking at a deficit there. And then as I think you alluded to, that this aging population has more data, but we're also having a lot more research data generated. Right. I saw a statistic at one point that what a specialist might read about 6% of the literature in their specialty in their lifetime. And then I really love that you pulled out that thing about chronic diseases, because that really is, we've gotten very good at acute problems like infections and broken bones, right? You go to a hospital with a broken bone, there's not much question of what they're going to do about it. And we're pretty good at treating infections and acute things. But the problems we're seeing now are chronic ones. You're more likely to die today from a heart attack, from complications from diabetes, from Alzheimer's, from cancer. These are all these chronic things. And addressing those is just super hard, particularly when you have a lack of healthcare professionals and an aging population that has more chronic problems, as you said, more data records and more of this explosion of information. How do you keep up, which leads to less doctors because they burn out faster. And to date, technology hasn't really helped with that. The EHR came in, and I would argue the EHR is incredibly important to healthcare. Just imagine trying to do healthcare today without electronic billing, right? That just would be a total disaster in today's world. So I'm not anti-EHR, but I also recognize that it has flaws in how it's addressed a lot of these problems. It hasn't really made a big difference in care as much as it's made a difference in the administrative side of healthcare. But I think AI's got the potential of changing that picture. For the first time, we actually might have technology that might help, not replace doctors, but might help doctors to deliver better care, which I'm really excited about.
Yeah. And even before you even get to delivering care, there's so much scope within healthcare to have a huge impact. I think it was Peter Drucker, like kind of like managing consultant kind of thing, and he was saying that the most complex form of human organization that we've ever attempted to manage is healthcare, right? Because not only is there complexity from the biological things that Sam mentioned, but just so many factors involved in it and so many use cases outside of just diagnosis. That's what everybody's drawn to, right? AI can cure cancer or diagnose more accurately than a doctor, but there's a lot more involved there. And like you said, Sam, the EHR has brought about huge opportunity because we have some sort of semblance of data organization, but we also want to make sure that that data has been leveraged correctly. A big portion of it might never get read, or a large portion of it is unstructured. I heard upwards of 80% of an EHR is unstructured, which means that somebody has to try and either read that, which is labor intensive, or it just gets ignored, in which case, why are doctors spending so much time collecting this information in the first place if it's not going to be used?
Yeah, no, I totally agree with you that focusing on diagnostic is not actually where I think we're going to get the biggest squeeze. I think the problem around chronic conditions is generally by the time you diagnose them, it's too late. What you really want to do is get to the person and help them change their behavior long before that. And so where I see AI helping is in how do we actually do effective behavioral modification? How do we have a system that can actually reach out to patients on a regular basis and not in an annoying way, actually provide them with the kind of help that they want? I mean, I think a lot about Candy Crush, which is this highly addictive game for about 6 months. You start playing Candy Crush, you just can't put it down. And then a lot of people get bored and they stop playing it. There's some people who stay addicted forever, but a lot of people sort of burn out on it. And I think we see that sort of thing happen a lot in any of these behavioral modification programs. You look at drug adherence programs and you see there's a big drop off after 6 months. And then after a year, just about everybody's dropped off of the program and not following it anymore. But what if an adaptive AI program could come along and change the game on them in a way that kept them interested? So I think that, that's a non-diagnostic, but it's still a really powerful tool. But also, there's a whole bunch of administrative stuff, which the EHR helps with, but could even be helped better with AI. And there's still a lot of work that happens in a hospital outside of the EHR because it's just not cost effective to try to capture it within an EHR. And AI can make it cost effective in that you can have this kind of adaptive automation that figures out what's necessary in that particular situation for that particular patient in that particular facility. So yeah, I love the fact that you're just pulling on that thread that we get so focused on what I consider kind of predictive AI around how are we going to predict whether this person has this condition or not, and missing a lot of the possibility.
Yeah. And one of the things that I think you touched on earlier as well, Sam, is the fact that these agents, so I see it like there's two sides to it, right? There's this full automation that can happen in the background. It takes some data, it processes it. It might be using AI or it might not be using AI, and it, can produce a result. But another aspect of this human in the loop, which I think is going to be really beneficial in healthcare, because it's such a high risk environment, you need oversight, you need this kind of experts being aware of what's happening and making that final judgment. I think that's one of the key things that we can do with agents in an A to A, or, have this kind of human in the loop as an adjudicator or as a judge, to say, okay, like, let's organize the data in such a way that the human has the final decision, but has to do minimal amount of effort to organize all of this stuff. Click here, get this document, move over to a completely other system, get this document. And,
Yeah.
like, there's a lot of work that you can do, even in the non-clinical realm, like you talked about revenue cycle or value-based care, that kind of stuff. In Canada, it's value-based healthcare, but it's the same kind of thing where you need some sort of information that's clinical. So you need to bring information from the health record, but you want to keep a human involved in that process, right? Because there's an impact.
Oh, yeah. I think it's about the computer and the human working together, not about replacing humans or even just seeing the human as a facilitator or final judge. I mean, I definitely believe they need to be the decision maker in the end, but I think it's about how they work together. The example I end up talking about a lot is patient discharge. So you have a hospital, you've got a patient in a bed, that patient is ready to go home. Obviously, the faster you get that patient out, is better for the hospital because they're, that's money that they're not going to be able to charge for while that patient is sitting in that bed waiting to go home. But even putting that aside, it's better for the patient, right? The patient is better off at home or in the skilled nursing facility or wherever they're going. And, there's lots of data out there that shows that people are better off once they get out of the hospital. But that process is just super complicated and varies a lot from one facility to another, but especially from one patient to another. So like I was talking with our CTO the other day, and he was telling me stories about going into the hospital, and he got put into the stroke ward, not because he had a stroke, but that was just where they had a bed. And in order to get off the stroke ward, he needed a sign off from physical therapy, even though his condition had nothing that physical therapy would be interested in. So they had to run around trying to find a physical therapist to get him out of the hospital. And that's the kind of thing which AI could get out ahead of, right? An AI system could have been working with the person who was trying to get him discharged to say, hey, I see this exception here of this patient who's going to need physical therapy. How about I reach out to physical therapy on your behalf? And you don't have to run around the hospital trying to solve that problem. I think those are some really interesting possibilities that we have.
Yeah. Yeah. I love that discharge use case because in a way, it's administrative, or there's an administrative role to it, but it still involves, like, somebody has to know that that patient wasn't there for a stroke, which involves reading some information and understanding what's actually the cause. There's a use case that I presented on as well earlier this year about the referral process. Um, Again, there's a lot of administrative work there, and even just finding the right specialist. If I'm making a referral and I'm a family doctor or a primary care physician and I have a patient, they come to me, I make some diagnosis and say that they need to see a specialist. There are lots of different specialists that you could send that patient to. I think in CMS, they have a data repository of just subspecialty types. And I think there's 850 or so subspecialty types. So you can imagine, okay, I have a heart problem, but there could be 15 or 20 different subcategories of cardiologists that patient could see. And how do you know who the right person is? And they have to be local, and they have to local to the patient. You can't send somebody across the country for something like that. And then when it comes to collecting the information from the health record that's relevant to that particular referral, you have to have some understanding of what that specialist would need, right? So patient records are huge, right? We see long patient records with hundreds of documents uploaded just in media, right? As well as the actual structured record. And then you have to decide what's relevant. Because if you send a book over, the specialist isn't going to have time to read that. If you're sending them to an orthopedic surgeon, they need different information than a cardiologist. So how do you differentiate between relevant information? And this was a side project that I was working on with some data scientists, just as a thought experiment, to build out a multi-agent framework to actually solve for this. And you could just keep iterating. You could take that and add another agent to do some other part, a set of agents, and there's no telling where you could stop with this. You could build a whole health system full of agents.
Yeah, that's going to be a shift really for how developers and how people think about computers that I'm really interested in seeing how it plays out, right? Because what you're talking about is a network of agents where you kind of train them about what referral means and how to understand the information and what to make available, but you haven't coded them to do that, right? You haven't given them an if then else set of statements. I'm really fascinated to see how this sort of plays out in that we're going to have to switch our mindsets. As you know, my history of that is as a developer, so I can speak as a developer. We're going to have to change our mindsets from being people who logically break the problem down into if then else statements to people who understand the domain and teach the computer about the domain. And I think that's going to be a really interesting shift as we move forward. And it's going to particularly play out in healthcare. And the reason I think it's going to particularly play out in healthcare is because healthcare is what needs it. I think about the statement that necessity is the mother of invention. The general ledger has existed for several thousand years. We understand it pretty well. And while an agentic system might be nice in finance, it's not strictly speaking necessary. But in healthcare, we have this problem, which you pointed out. It's the most complicated system. I read somewhere there's maybe 10 billion credit card transactions in the US last year. But there are over 1 trillion cells in your body alone. It's just an order of magnitude complexity. And then pretty much every credit card transaction looks more or less the same. It's going to vary a little bit. But your health data is going to be dramatically different from my health data. You might have, one blood pressure that's been taken once. I might have a blood pressure that I take every week. And so the sparseness of the data in healthcare creates this real problem. And as you say, a specialist needs access to the data that they need access to. If I go see a psychiatrist, they're not interested in all those blood pressures.
Yeah.
And they don't want to have to read through all those blood pressures to get to what might be interesting to them. So I love you talking about, how AI could help with that process, but we also have to make sure that we're being responsible, because the potential for the AI to either miss or make up data is still there and still a very real thing. So at the same time, I'm also interested in how we're going to get those guardrails in place and how we're going to think about it from a point of view where we're not putting it at risk, where that specialist ends up seeing a document that's not accurate.
Yeah. And I think a lot of the work that I'm doing right now, or people like me are doing in collaboration and really close collaboration with clinicians, is setting up those guardrails. Like for the referral project, we spent a lot of time on evaluation, and writing these evals or evaluations are key. You have to, like you said, teach or guide the model. And there was a paper recently from DeepMind. It was around like having physicians having their oversight, but having their oversight in building those evaluations as well. You're setting the guardrails. The guardrails in healthcare have to be sort of non-negotiable, right? You can say to an LLM, keep it to 500 words, and it might do 510 words, right? It's not very good at counting. But in healthcare, you can't say, show me all of the blood pressures, but don't count blood pressures, to use your example, from the emergency ward. Say, go in, I twist my ankle, and part of the triage is somebody takes my blood pressure, but my blood pressure is way up, right? Because I just twisted my ankle. You don't want that to be part of a clinical record, because that's going to trigger all sorts of flags, right? You're going to say, okay, this is Michael Lynch. He's like super high stress,
Yeah. Figuring out how to sort that out, and then also figuring out, what we're doing in the AI transparency project in HL7 is talking a lot about how do you just make it obvious to people that AI was involved. because AI is going to produce a result, which it's wrong to say it's confident in it because that implies that it has an idea of what confidence is. But it's just going to produce what it thinks is the next best result. It's up to making sure that the human on the other side understands that there was an AI involved and understands that this data has some probability in it. I mean, healthcare is all about probability. A differential diagnosis is a probabilistic calculation that doctors are doing every day, all the time. But we don't really want to admit that. I think in the end, we psychologically need to believe that our doctors are deterministic because we're putting our lives in their hands. And so we train them in this way to present themselves as deterministic. Right? All of med school is teaching them about how when you go to a patient, you should seem as though you have an answer because that's what they're looking for, and that's what psychologically we need. And so we shouldn't blame doctors for that because that's what we're asking them for. But in the inside, it's really probabilistic in nature, and if we can evolve to start embracing that, which I think we're going to have to do with these new AI tools, it's going to be about understanding where the data came from and what's the probability around it, not about having certainty. In the end, certainty is unfortunately not something we can actually have.
Absolutely. I'm wondering if for HL7, the plan is to distinguish between outputs from a model that were a classifier versus from a generative model, which can hallucinate.
Yeah, so we're talking about observability in this project, and we have what we call levels of observability. And the first level of observability is just knowing that an AI, some algorithm was involved in the creation or a modification of this data. That's just the first level. But then there's a bunch of other levels below that. One of them is understanding, as you say, was it the distinction I make is between a deterministic and a non-deterministic AI. So a deterministic AI is essentially a bunch of if-then statements, which is always whatever input you give it, you're going to get the same output. Then on the other side, you have non-deterministic AI, generative AI fitting into that category of you give it the same input, you might get different output. A lot of people recoil about the fact that we have this non-deterministic things running around, but I think in the end, what we're going to find is that those non-deterministic systems are actually much more powerful than what we have been clinging to in the past in computing, which is to try to get the computers to be more deterministic. So we're going to have to embrace that non-determinism. But yes, there's a level of just exposing that. Then there's a level of, say, bringing in what organizations like CHI, the Coalition on Healthcare AI, are talking about model cards that can describe the model that was used. And so we're talking about that as another level of observability. And another level of observability is having a understanding of the data that was brought in to make the prediction. So both the training data, but also you submitted a bunch of original documentation in order to come up with a summary. You should be able to trace back to that original documentation so you know where that summary came from, so you can verify some of the facts within it to see, is this coming out right? So we're talking about a lot of those different levels. And, as anything in the standards community, it's going to be about maturity over time. We're not going to solve everything day one, but
Yeah,
it's really exciting stuff.
Yeah. Sam introduced me to the AI transparency on FHIR and the work that he's been doing there. And I love the idea because that's the direction it's going. That's the direction I can see things going from different projects. And I love that last point, Sam. You can think about grounding. The AI has made some determination or prediction, but what is the evidence that it used? And if you can surface that, if you can have some sort of not really a disclaimer, but somehow identify to the end user, okay, this was a determination that was made because of this evidence, and ground it in actual documentation or different sort of FHIR records or observations or whatever it might be, then it helps the user because they would probably have to make that decision, probabilistic decision, as Sam mentioned, but it sort of gives them a little bit more confidence as to, okay, I know it's clear that this is not deterministic. It's a real data point, but it's coming from AI or through AI, but it has grounding in these pieces of evidence to support it. And I think that, yeah, that work is going to really be helpful. And I can see how there's lots of scope to expand that work as well as you decide, okay, how much confidence do you want to put? And I know confidence is a hard word to say. How much confidence do you put into this solution or this AI categorization or summary or whatever it might be, and balancing those two things. And firstly, being able to identify it and have those different groupings is key to moving forward.
Curious what you both will think that the most complex data to deal with are.
Yeah, that's a great question. I think Sam touched on it around the sparsity of data. That's one of the harder things to deal with. If there's missing data, or you have some data, but it could be a human that entered that and they might have not read something correctly. So it's not that we can like rely that this is gold ground truth data and it's like it's perfect. That we have to deal with the sort of like the imbalances of that data, and like I said, the sparsity. Like it's somebody who's like 70 years old with like 5 different comorbidities or something like that is going to have a lot more data than say a 28-year-old who came in and fractured his knee. There's a lot of variation. And like I mentioned, I was at the start of my career, I was working on a lot of pediatric stuff. And that was at a time where we had to go around and collect data to build these models in imaging. And I was working for a large company. We were able to connect 3 of the largest children's hospitals in Europe, in the UK, in France, in Italy, to start to bring together some data to learn as much as we could. But even within that project, there's disparity between the devices that it came from. The device from manufacturer A and you had a device from manufacturer B, it's the same CT, it's the same MRI, but the data, the encoding, the inverse functions that it ran through to actually produce the image were different. And you could visually maybe spot the difference, but once you actually get down to kind of learn on that data, those differences became huge. And there's a lot of work that had to happen there.
I've definitely seen that. I mean, I think, yeah, the temptation is to always think about the unstructured data as being complicated, but even the structured data. So we did a project for a large state in the US on COVID reporting. They were trying to pull in all the COVID tests from across the state and report on them. And we took a look at the data and we found that there were 40 different ways that negative was coded. This is COVID. This is not like very historical data, but we were getting these lab feeds in, and there were 40 different ways that those labs were expressing that the result of the test was negative, and similarly over 40 different ways for positive. And then there's, I think there was like 50 or 60 different ways they were even expressing the test itself. So that the permutations there are just massive in the data. And when you try to do things like train an AI, as you say, off of that data, it very easily can miss correlations between data because it's so sparse and so messy. I think that creates a real challenge for the industry. There's tons of reasons for why that is true in this industry, and we could go in deep depth into the history around that. But I think the important thing is not to make assumptions about data. It's to understand, as you said, I love that you pointed out the fact that just because it's written in a medical record does not make it necessarily true. There's always a non-zero chance that there was a mistake made someplace in the process. And that's just the nature of reality. And it gets back to this fact that we have to learn to deal with non-determinism. We actually do deal with non-determinism, right? Every day. I'm talking to you right now, and I have no way of knowing what the next thing you're going to say is. We haven't scripted all of this ahead of time or anything like that. And yet I can be pretty sure that you're not going to curse me out in the next little segment. And the reason I can is because there would probably be negative consequences for you if you did that. So we as a society have built all kinds of systems that help us deal with non-determinism all the time. Similarly, doctors are used to picking up a medical record and looking at it, but understanding that there may be flaws in that medical record, not just taking it as gospel. We need to have AI learn to do the same sorts of things. One of our big struggles is going to be figuring out how to put AI in pain, or in other words, give it actual consequences. When we crack that nut, that's going to really help us build trust, because healthcare in the end is all about trust, and working with data is all about how can you trust that data.
Yeah. And there's a quote that I heard from somebody that healthcare moves at the speed of trust. You hear sometimes people say healthcare moves slowly in technology, but I don't think it does. I mean, it can move fast, but it needs to move at the speed of trust. And I think more than ever, as we bring in more AI, we have to work even more closely. Like I'm lucky, like I said, I've worked in health systems, so I've worked really closely with clinicians and having a really good rapport with them as we're driving technology into the health system. But even now, it's more than ever, giving them the ability to help them also create these evaluations and those guardrails and these understanding of how these systems work to a certain extent. At the weekends, I tutor part-time at this Michener Institute, which is part of the University Health Network in Toronto. And we're working with continuous learning, people in healthcare who want to learn more about AI. And I've seen a shift in the type of people that were coming. At the start, it was epidemiologists or people who are more on the statistical side and the numerical side, whereas now we have surgeons coming to learn about, and we talk to them about the fundamentals that underlie it. They might not need to understand the difference between an encoder-decoder transformer and decoder-only transformer, but they need to have an understanding of why an LLM might be making a statement or a decision, and what information it's using, and where does that information come from, and all that underlying stuff. So everybody is learning together in a certain way. There's a lot of people that are getting up to speed on these technologies, and bringing them into the conversation early and frequently is going to help with this rollout of solutions so that we can move at the speed of trust and also not stagnate.
Do you think that with HL7, with technologies like de-identification, with MCP for agentic communication, with FHIR and OpenAir, is all of that together enough to get to what you envision would be the ideal state of healthcare? Or do you think anything's missing?
All of these tools are all amazing tools, but I think I mentioned earlier that it's all going to have to be on a backbone that handles this asynchronous communication effectively and at scale, which is, honestly why I joined Vantiq, because Vantiq has that kind of platform. I think that that's going to be key to making all of this possible. A lot of people talk about the idea that, okay, well, standards are dead because we have LLMs now. People are not being realistic there about a number of things. One is which is the cost of running these LLMs. We have, as a world, been largely insulated from that because most of these companies are running at a loss. There's just big money behind them betting that one day they're going to not be at a loss, and I suspect they're right. I suspect that one day there'll be an infrastructure that's very much dependent on them, and they will be very much worth it. And over time, they'll get less expensive, and we'll be able to run them on smaller hardware. All that sort of stuff will happen. But it's never going to get rid of that need for there to be standards in order to compress that data and therefore reduce the cost of using these tools. I do think that that to me, the big problems still to be solved around this are, one, understanding how we can teach them over time, so how they can have effective memory. We can certainly record everything that the agent does and then play it back for it, but humans don't do it that way, as far as I can tell. As far as I can tell, humans remember the high points, right? You remember particularly the negative things that have happened to you, and you remember the really good things that have happened to you, and then your brain summarizes that up and uses that summary going forward. So I think uncovering that kind of thing, which we're actually about to do some research with Worcester Polytechnic Institute around that, and seeing how we can do that effectively, which I'm really excited to get kicked off. And then it's about that asynchronous communication in that context. How does one agent know which conversation it's engaged in, as it's engaged in many, many different conversations that are floating around? And finally, how we put those guardrails in place. That is super important. And those three pieces, I think, we're still kind of missing. We have pieces of all of them, but those are the new frontiers we're going to have to crack in order to really have adaptive automation working effectively for us.
Yeah, I agree with those three as well, Sam. And like maybe over emphasize the last one, especially having those guardrails in place, I think are key. And all of the things that you mentioned, Patricia, are key to making that work. And they're all sort of tools. And the assumption is that all of these things are going to also advance the tools that we're using, the standards that the teams are working on, and also having the proper guardrails there to keep us safe.
And do you think that the same infrastructure and the same tools look the same when it comes to thinking about healthcare from a hospital perspective to a city level's perspective, state level, national, international?
I think that the potential is similarly there across those different stratospheres. The scale of the data becomes very different, and the privacy concerns of the data become very different. And I think that's actually one of the things which is going to be interesting in how it plays out. A lot of people, not to get too sort of philosophical about it, but I always see this kind of cycle within computing where we talk about centralization versus decentralization. And there's always this rotation. And I think it actually goes beyond computing. Actually, you can see these same trends across the history of society where people have tried to go more larger centralized government than more distributed government, than more large centralized government. We've done very much the same in computing. And generally what we've ended up with is loose centralization of orchestration with decentralization being the most effective. So we're going to have to understand how we federate data rather than centralized data. It's kind of what that boils down to in my head. There's some really interesting work that's gone on around how do you do these things in federated ways. Red Hat has some really interesting technology that I've seen around being able to train models across multiple different facilities without them sharing the data, but with them all being able to share the model and get the value out of it. And as government agencies recognize the power of that and are able to help institutions work together without trying to move the data out of them, without demanding that they make their data available, but say, hey, we can all get value out of this data using these federated technologies, that's going to make a big difference to how we are able to solve some of these problems at all those different levels.
Yeah. And to add to that, it happens right now. A physician has a panel of patients, and depending on maybe geography, that demographic changes. But we also have national disease registries, which try to collect data across all of these many different subpopulations to make some assumptions on disease progression and care plans and all this kind of stuff. So it does happen right now, but I guess maybe going back to one of the first things we talked about, this is also very labor intensive. You can't just send over huge chunks of data. So there's always some sort of abstraction to that data. So you extract certain information from it. And I think that's going to continue, but maybe with more fidelity and better understanding of the data and anonymization, like you mentioned, Patricia, that's part of it too. Who needs to know that it's Michael Lynch's X-ray? At what level? That comes into play then as you really understand and abstract some of the trends out of that data.
We are almost at time. Any last thoughts, final words, anything about how people can contact you or learn more about your work that you'd like to add?
Sure. I'll just say, I just returned to, I know there's a lot of fear and a lot of trepidation around what AI is going to bring to our future. I think that it's like any other technology shift that we've gone through in the last 1,000 years. It is going to cause pain, and that pain is going to be real, and we shouldn't ignore it. But the potential to actually help people is just amazing. And so we can't just put our heads in the sand because that just never works. We have to embrace it, but we have to embrace it responsibly. As Michael's talked about a lot of the guardrails that we need to be thinking about, and we need to continue to emphasize that, but also embrace it and recognize that this is just really an exciting time. We're going to have the potential of addressing problems which we just would never thought were possible to address before. And yeah, I'd love to continue the conversation. People can find me on LinkedIn. You can also find me on my YouTube channel, which will have a description here where you can we can share those links. But I have a number of talks on YouTube where I've talked about this technology and how it can impact healthcare. And then you can certainly reach out to me at vantiq.com if you're more information about that platform.
They're great talks. I really recommend folks listening to this to go take a look.
Yeah, I would add to that as well. Yeah, or second that. Yeah, good talk, Sam. Yeah, for me, like Sam said, I'm really excited with the possibilities. I feel like we are at a stage where, when I was doing this work in the early 2000s, we were, training small models to help radiologists, whereas now we have the ability to leverage these already pre-trained models to take advantage of those to do some fantastic work. And yeah, likewise, if people want to reach out to me, I'm happy to chat about this and other topics. You can find me on LinkedIn, although there are a lot of Michael Lynches, so you might have to scroll to page 2 or 3 to find me. And yeah, it's an exciting time to be in this space.
And Michael also has a really interesting talk on MCP and agentic AI within healthcare through aggregate intellect. We'll link that in the description as well.
Awesome. Thanks, Patricia.
Thank you. Brilliant. Thank you both so much. This has been such an interesting conversation. Really grateful for your time.
Well, thank you so much for inviting us and hosting this. It's really, really wonderful to see people having these conversations across healthcare, and I really appreciate you taking the initiative to make sure that they're available for everybody to take a look at.
Yeah, thanks, Patricia. Nice job.
Thanks for listening. Before you go, a quick note about the company I co-founded, Private AI. We help organizations use their data safely so they can build compliant AI products, share data securely, and extract insights without the regulatory headaches. If PII, PHI, or PCI data are standing between you and your next innovation, visit private-ai.com. See you next time on the Data Frontier.